So hi, I'm Dr. Peter Bernstein. I am the director of the Division of Maternal Fetal Medicine here at Montefiore Medical Center and the Albert Einstein College of Medicine.
Hi, my name is Lisa Nathan. I am the medical director of the Labor and Delivery Unit at Weiler Hospital within the Montefiore Medical System.
I mean, beyond sort of the medical condition, there are challenges in caring for pregnant women on a labor and delivery unit with this infection.
With regards to just frequency of having to go into the patient's room, if we're talking about, we can just take a patient who's not critically ill with COVID-19, but someone with mild disease or even asymptomatic who is there for delivery. When you are taking care of someone on a labor floor and having to go in and out of the room potentially every hour, every 2 hours, if you're adjusting medications such as oxytocin, or if you're needing to do exams, it's a lot of in and out and a lot of contact with someone who's positive. So a lot of donning and doffing of PPE, which just that process itself can be risky. So there are a lot of challenges from that standpoint. Those challenges increase, of course, if you have a severely ill patient with COVID-19, pneumonia, who's hypoxic, requiring various degrees of oxygen therapy, where you have more of the aerosolizing concern, where you could aerosolize the virus. And those patients, there are a few things that we started to do on the floor, for example, for titrating oxytocin, which is something that you can increase every 20 to 30 minutes, rigged up extended IV tubing to be able to bring the machine outside of a patient's room, for example, so that as long as the patient was stable and didn't require us to physically be taking care of her in the room, we could at least adjust her medication from outside the room to reduce exposure, reduce the amount of PPE being used, for example.
One of the other challenges is that we had quite a number of women who, initially were discovered as having the infection but were fortunately not sick enough to stay in the hospital, but we were very concerned about them. I guess I'm driving at how we manage these patients who we discovered were COVID positive, but coming from not just our practices, but from other practices, and how we monitor them even after they went home.
Yeah, we very early on, as we started to see the increase very quickly with the number of cases that we were diagnosing in the hospital, we started a list, and that list was within our EMR. As they came back positive, everyone was adding these patients' names to the list, and those that went home, whether it was a discharge immediately from the triage unit or after a period of inpatient management who were discharged home, we discharged them with a pulse oximeter, and we created these lists and had a nursing staff who were calling them up and following up for days, several days in a row, and then spread it out to every other day, I believe, and then to at least once a week until the symptoms had fully resolved. And we did catch a number of patients from that who subsequently came back in as the symptoms started to worsen. So it definitely proved to be effective.